Hello and welcome to another Applied Radiology Expert Forum webinar. And before we get started here, let me take a moment to thank all of you from around the globe for joining us this evening. We really appreciate the time. In this program, we'll discuss AI-enhanced cardiac imaging for longevity. And to do so, we've assembled an exceptional multidisciplinary panel of imaging professionals, each of whom brings a unique perspective on cardiovascular imaging, structural heart disease, preventative cardiology, AI innovation, and global cardiovascular care in general. I'm Kieran Anderson. I'm the group publisher here at Applied Radiology, and I will be your host today. I'd like to thank Canon for sponsoring this Applied Radiology Expert Forum program, which is part of their Perspectives webinar series. We are grateful for their support and hope that you'll all enjoy this program. So, before we get started, let me mention just a few things. First, in our resource area, we've included a PDF of an article that Dr. Sengupta recently published in our Eye on AI section of Applied Radiology, and we encourage you to view that. You can download that at your convenience. You'll also find additional links there to webinars and articles that have been part of previous Perspective webinar series. In addition, you are encouraged to submit questions at any time for consideration. Finally, we've also included an audience survey to help us understand how we did today, and we would truly appreciate your participation. And while we cannot guarantee the quality of your internet connection, should you lose audio or video for any reason, please simply refresh your browser, as that often solves the problem. So with that, let me now introduce our moderator, Dr. Partho Sengupta, who is Chief of the Division of Cardiology at Rutgers Robert Wood Johnson Medical School, and also Chief of the Cardiovascular Service Line at the Robert Wood Johnson University Hospital. Dr. Sengupta, many thanks again for joining us here today and agreeing to moderate. I'll now turn it over to you to introduce the rest of the panel.
Thank you very much, Kieran, for having us here. I'm so delighted and excited to join this distinguished group of people as a moderator myself. My work has been focused on AI-enabled cardiovascular imaging, multimodal phenotyping, digital cardiovascular models, and scalable approaches for early detection and prevention of cardiovascular diseases. Much of today's discussion, however, will center on how imaging and AI can move cardiovascular care from episodic diagnosis towards continuous, personalized, and anticipatory care model designed to preserve cardiovascular health span over time. And I'm so excited and delighted to introduce our panel. First is Dr. Canon Mukai, Medical Director of Non-Invasive Cardiovascular Imaging at Salinas Valley Health in California. Dr. Mukai is recognized for her work in multimodality cardiovascular imaging and for advancing patient-centered approaches to imaging innovation. Her perspective uniquely bridges, as you will hear, advanced imaging techniques with patient experiences, workflow designs, and equitable implementation of AI in clinical care. Her recent work has emphasized on how AI can support not only diagnostic accuracy and efficiency, but also trust, communication, long-term patient engagement across the imaging journey. Welcome, Dr. Mukai.
Thank you.
Our second panelist is Dr. Sanjeevan Pasupati, Director of Structural Heart Disease and Cardiovascular Services at Waikato Hospital from New Zealand. Dr. Pasupati is internationally recognized for his expertise in structural heart interventions and complex procedural cardiology in general. His work spans advanced imaging-guided intervention to transcatheter therapies and integration of imaging into procedural planning and decision-making. And although he's one of the proceduralists, he uses extensive amount of imaging during his work, and therefore I think he's absolutely essential to this discussion. He brings an important global and pragmatic perspective on how AI-enhanced imaging can improve procedural precision, efficiency, and patient outcomes in increasingly complex cardiovascular population. Welcome, Dr. Pasupati.
Thank you.
And last but not the least, Dr. Zhao Lima, Director of Cardiovascular Imaging from Johns Hopkins School of Medicine. Dr. Lima is one of the pioneering leaders in multimodality cardiovascular imaging and population-based cardiovascular phenotyping. His contributions are enormous and have fundamentally shaped our understanding of subclinical cardiovascular disease, cardiac remodeling, vascular aging, and the role of advanced imaging in preventive cardiology. His work has been central to very large number of large-scale longitudinal studies evaluating how imaging biomarkers can predict cardiovascular outcomes long before overt disease manifests clinically. Thank you, Dr. Lima, for joining us.
Thank you, Partha, for the kind words, and it is a pleasure to be here and join you three on this panel. Thank you.
Wonderful. To set the stage, let's talk about cardiovascular diseases. We know that if you look at the projection, the burden of cardiovascular diseases is expected to rise dramatically over the next several decades, not only in total cardiovascular disease, but also in stroke, heart failure, atrial fibrillation, coronary disease. That means we are moving towards a future where imaging cannot remain purely reactive or episodic. However, we are today talking more about health and how do we preserve health and wellness. The question becomes, how should cardiovascular imaging evolve if the goal is not simply detecting established disease, but identifying early functional decline, guiding prevention, and maintaining cardiovascular resilience over the life course? And that will be the theme of our entire discussion today. Let's start with some pertinent questions. Let's start with a question to Dr. Mukai. This is now with regards to cardiac diagnostics for supporting earlier and more precise decision. Dr. Mukai, AI has evolved from concepts of machine learning, deep learning, to know what we call as a large-scale era currently. For the benefit of our viewers, could you just walk us through this evolution and which of these techniques has had the biggest impact on cardiac imaging?
Thank you, Partha. Yeah, so as you know, AI is really mainstream at this point in time and really is focused on performing tasks that simulate human intelligence and problem solving. So if you focus on it from the standpoint of what the specific aims are, AI, artificial intelligence in general, aims to create smart machines. A subset of that is machine learning, where you aim to have the machine learn through data to solve problems. It's usually through a very defined data set. A level above that is neural networks, where you aim to automatically identify patterns for feature detection. That typically requires identified data sets. And a level beyond that is deep learning, where you aim to automatically learn from large unstructured data. I would say right now for cardiovascular imaging as a multimodality imager, I do use actively a lot of features and products that are currently in the market right now that do leverage deep learning. A lot of this is intended to facilitate and improve physician-directed interpretation and assessment. And I would say that's really where we have the most activity right now in the mainstream. Back to you, Partha.
Perfect. That was a very succinct and a beautiful overview of the field. I think I've never heard a response from an imager which so succinctly summarizes the entire field. Thank you, Dr. Mukai, for doing that. Now, there are many targets for AI applications across the primary activities of cardiovascular imaging chain. And this can be seen in one of the slides. And I mean, perhaps to frame the discussion more broadly, what do you think, each one of you, which of these fields that is related to AI can realistically change the cardiovascular imaging over the next 5 years? And is this really a hype? Look at all of the different aspects imaging is supposed to contribute to. Maybe I will start with Dr. Lima. Dr. Lima, what do you think?
I think AI is positioned to produce big changes. I think over the presentation here, as you mentioned, Porto, it comes from planning procedures, but also preventing disease and enhancing diagnosis. MR, for example, magnetic resonance image, is positioned to benefit tremendously from AI, and that we feel already in every aspect of MR imaging. CT as well, every modality basically in imaging. So I think we are feeling already the impact of this wave, and it could bring wonderful things. Of course, we have to be very attentive to the pitfalls that we are going to be discussing in this seminar.
And that was I would just extend maybe asking you one more question, Dr. Lima. You do a lot of work in the field of MRI, and I've heard about how some of these models are now going into the machines and making life easier for not only the images. Could you expand upon how it's impacting the workflow actually in perhaps in some of the labs that you have seen around?
Yes. The main impacts for MRI have been in data acquisition, because data acquisition before was really burdened by how much scout imaging you had to do to find the heart, to position yourself the right way. This can all be done automatically, and we generally do it in 5 minutes, and we are ready to go. The other area, what has been a sea change of progress, has been in MR reconstruction, and there I highlight two aspects. One is that Cine is now works on everyone. And I'm also impressed with T2 mapping. For those who are in the MR field, T2 mapping has always been sort of unreliable because of the noise. AI has reduced the noise and has made T2 imaging for inflammation in the heart and in other organs really achievable, reliable, and I think that's a result of AI that you can palpate.
And that's amazing. And some of these biomarkers that are seen on MRI, like inflammation and other biomarkers, tissue level changes, are so important for subclinical disease and a big impact to the understanding the pathophysiology of disease and how this could be detected. So this is very critical evolution, I would believe, in how we are moving through. I could probably bring that same question to Dr. Pasupati and see what he thinks about how it's impacting his field.
Yeah, I think, thank you very much, Dr. Senguta. And it's an amazing answer from Dr. Lima to kind of set the stage here. I think in the interventional cardiology, I think there's still the hype is about AI being a complete autonomous thing in the next 5 years. And I think that causes a lot of concern and fear for the population. And is it completely generalizable? Where are we with this program at the moment? I think they are still, I believe, will be a hype in 5 years. But what I really see is the AI to work in collaboration with the human as a second reader to start off with the programs. That is kind of where I see the field is setting up. And there are two components in the structural heart disease. One is the diagnosis. So the preventative diagnosis and the early diagnosis, where the AI will actually, it's very good in making diagnosis, but it'll most probably work as a second reader where it'll highlight red flags. It'll tell you these kind of patients are sick. These kind of patients, you need to do something. And the clinicians will still need to be able to make that decision, to decide how to implement that diagnosis for you. So that is the first component where I see the AI is going to make a biggest difference for us in the structural field, especially with the late and misdiagnosis. The second component is AI will make a big difference in the precision and the accuracy of how you intervene in patients. They will be more generalizable. We'll be able to work more precisely and also predict when we start to intervene in the patients what the outcome is going to be. Because at the moment, it's a kind of a blind field. We go in thinking, okay, this device is going to work very well here. Is it going to leave a leak? is it going to be appropriate for the patient? I think that is kind of where I see the next 5 years we are going to make a major change with AI integration.
Great. And I'm going to turn back to Dr. Mukai. So, Kane, what do you think has been your experience? Is this a hype, or what do you think?
I think the technology has advanced quite a bit. Right now, it's mostly the emphasis is on supervised learning and also physician-assisted utilization of the technology. So I think the main thrust and what will develop the most over the 5 years is going to be physician-assisted diagnosis and interpretation of a patient, but being able to identify multiple nuances of, say, for example, the myocardial tissue work can be through mapping, for example, T2 mapping, as Dr. Lima mentioned. Another example within CT has been plaque. So, for example, in the past, plaque, we just look at the original images, we assess how much plaque stenosis there is. Now there's this complete entire field of plaque characterizations, high-risk plaque. And now with the additional features that we have with the deep convoluted neural networks, we have features that can identify plaque volume, for example. And there is actually a nice white paper that's come out a couple of years ago about plaque progression and how we can treat plaque almost as it is a staging for cancer, and how do we promote regression through therapies, and that will become targeted therapy. So I think the one area, a good example I can think of right now that's fairly close to achieving longevity, improving longevity through tailored treatment would be, I would say plaque would be one good example. But I would say though, there is some caution. We have to definitely understand the quality of the data. We have to also be equitable with the data set that we collect. That is the biggest danger, I think, if we use the data that's available to us without discrimination. We risk having quite a bit of bias in our data sets. So that is the one part that I would say is potentially a hype. We're not quite there yet. There's a lot to do, but there is a lot of promise.
Awesome. I think you nailed on very important concepts here. And those were, for example, the plaque is a perfect example of a subclinical disease that starts, and the biology to visit that and do perhaps mass level studies and understand people who may have different responses to different therapies. In fact, even understanding and finding what drugs work and what do not work. And perhaps if you're looking at people at an asymptomatic stage, you will not have any symptoms. You will have to probably go by imaging and see whether it is stabilizing or regressing or what's happening. So I believe this is a very strong inflection point. And I think also I like the answer about the words of caution as we are understanding the biology, having the right representations, right kind of data sets, so that our understanding and our models are not biased. So I think thank you for those insights. But I want to just go to Dr. Pasupati, because the biggest innovation in cardiology in the last decade or so has been the transcatheter, and what we have done remarkably with miniaturized, minimally invasive, and now transcatheter technique to change the paradigm of valvular intervention. However, valve disease doesn't happen like at the very end when we see them, and they go over decades, right? So is the concept pertinent in cardiovascular diseases? Will AI allow perhaps a paradigm of screening early and more appropriately, maybe for valvular heart diseases? Are we seeing patients too late, do you think?
Yeah, no, thank you, Dr. Partha. I think we are definitely seeing patients very late, especially I think before the transcatheter valves and things are developed, there were a lot of patients who are not even referred to us because they thought they won't get intervened. But that kind of concept continues to grow, where people have not even looked at diagnosing these patients. So the biggest changes are coming with ECG and then also with echo and CT. So the big revolution we see is this ECG, we only see squiggly lines most of the time, and maybe an acute MI or mild MI we see. These squiggly lines means a lot. There are even now single leads ECG from your smartwatch. There are trials that are being done to look at, can you predict MR? Can you predict TR? How can you work from that? And it's not only just predicting on the point of care, it actually works from this. It's a paper from Dr. Liang that talks about, can you work from here to look at progression? How would this MR prediction now will turn up in the next 5 years or in the next 3 years? So that kind of paradigm shift has made a massive difference, and it's slowly starting to get integrated into the ECGs. We also have problems with just diagnosing. So just take a common aortic stenosis. It is something that we see all the time. But there is a concept for low flow, low gradient AS, which doesn't fit into most of our criteria, mostly females who get, in fact, neglected by these diagnoses. And having echo parameters and AI reading these things has a much earlier diagnosis, better streamlined diagnosis, and we are able to manage these patients. We are also just starting to show these diagnoses has prognosis, and it translates into clinical health outcomes. And I think this kind of streamlined versions gives a better equity care in areas where different people have different expertise. And that is what the AI is bringing it in to neutralize that whole differences that we are getting with different people diagnosing them differently.
That's fantastic. Thank you very much. And I think I want to ask a very important question to Dr. Lima, is the traditional risk scores, right? So we don't use any imaging, we don't use any ECG, AI algorithms, or where do you think all this traditional risk scoring and will go? Do you think our risk prediction models will use a lot of AI and imaging in the future?
Yes, because the initial research that we have shows that if you want to predict events at a closer time frame, imaging is particularly important for that. So subclinical disease, if you're predicting at long run, traditional risk factors and other factors that are known to be enhancers are very effective. But if you want to predict events at a short run, then imaging is very, very important as a marker, as well as biomarkers. One example, if I may, Partha, is aortic disease. We measure diameters by CT, by MR, but yet half of the cases of aortic dissection happen in aorta with normal diameters. So there, I think AI can be very useful in identifying really what are the true markers of aneurysm, of aortic disruption. And there are a couple of groups working very diligently on this. I think that is the kind of development that will make a big difference.
But let me then just come back and kind of challenge you on, let's assume the AI says a normal size aorta, you are looking at it and you don't see anything abnormal, but it says it is that risky and there's a risk of rupture. How do you encounter this AI-driven diagnosis, which you cannot really recognize immediately with your eyes? And will that lead to overdiagnosis, over treatment, or maybe some degree of anxiety when patients get that AI label? How do we handle that? I think this is an important question, and I'm just starting with the question or the example that you mentioned, but it probably it applies to other applications as well.
Many applications, but this is a good example. For example, changes in shape really come before rupture, and those changes in shape are subtle. So if we can improve AI tools to pick up those changes that happen generally in borders of, and it's very interesting because this generally happens in embryologic borders. So it's very hard for humans at naked eye be able to identify that, but these patterns can be detected by AI, and that can be a big difference. Of course, one of the pitfalls is to rely on this too much, and in that case, you have anxiety and unfair management. And I think, as Dr. Mukai mentioned, and you too, one of the pitfalls of AI is bias. So we need data sets that are unbiased in order to create the necessary trust in AI that will allow us to use it the right way.
Yeah, and
Dr.
I think
Can I just
yes,
interrupt?
go
Just
ahead.
one little question, if I may. Just giving a practical sense of the conversation that we had with Dr. Limo is, at the moment there is a range of iota that doesn't require operating. Okay, you don't need to fix it. But when you go to an operating room, every time when it comes to the heart team, he says the surgeon can feel on the table the iota, and you feel if the iota is too thin or not right, you should fix it or you should operate. There's a lot of uncertainty here. When you go into an operation, if you can predict this well ahead of time and correlate that to what the surgeon does in the operating room, it will make the whole scenario much more pre-planned and much more predictable. And I see this an amazing future once the data sets are built up in this field.
So I think what we can summarize from this important discussion is that there's a lot of potentials, and we're just learning how to use some of this information. But this is amazing of what it could mean from visualizing a subclinical disease when we cannot really recognize that with our current understanding, to even going into an OR room and recognizing the steps before even you have opened up and understanding what to do next. So I think this is a great segue to something more pragmatic, and I want to bring it to Dr. Mukai, because she's really a proponent of how we implement them carefully. So many difficult to image patients have, like for obesity, atrial fibrillation, severe calcification, tachycardia, have the highest long-term risk, which AI-driven technology are already making a practical difference in these patients, which are really tough cases to image.
Yeah, I would say yes. No, thank you for that question. So I think a lot of this will be mostly with the DL reconstruction. So for example, with denoising, there's certain ways to use. It's sort of a step beyond what had existed about 10 years ago, and really maximizing the quality of data and the image quality, and also the data information that you can retrieve from a specific image, while shortening the amount of time that you can actually take on the scan. So for example, right now when I do MRI scans, I utilize specific features that improve the image quality. I can reduce the scan time by applying compression sensing, for example, with MRI, but I actually rely on the deep learning reconstruction. There's two that I actually use currently right now with my equipment, and that really allows me to shorten the amount of scan time, but not compromising the quality of the data. So I'll give you an example. I have some patients who have challenges going inside the MRI scanner. They're not able to stay on the table for too long. So we try to do a short scan time, reduce the amount of breath holds that's required, but lean in on the deep reconstruction to actually get the quality of data that you need. A second example is you can also lean in on those deep learning reconstruction algorithms to shorten the amount of time that it requires to do post-processing. For example, with MRI, as Dr. Lima mentioned, segmentation, figuring out the volumetrics, that is a very traditionally a very time-consuming process, but by leaning in on the denoising algorithms, you can actually significantly improve the time it takes to get the analysis data. So I would say the biggest ones will be essentially denoising from an MRI standpoint. The equipment that I use right now, I can actually use it also for CT as well. So for CT, you actually definitely benefit from reduction in your dose. So by having a shortened scan time, not requiring a long duration of scan, you actually can improve the amount of dosage, reduce the amount of dosage that the patient gets. So ultimately, it does translate very much directly into patient care and patient satisfaction.
Yeah, and I think that also leads me to asking Dr. Lima a question about radiation, like balancing the speed, radiation, contrast, exposure, and diagnostic confidence. How can imagers think about bringing a sense to all of these components as we become more and more integrated with some of these tools, AI tools?
Yeah, this is a great question, Part, because what the promise of AI, or one of the promises of artificial intelligence in this field, would be to bring to equalize technology. For example, we know that ultra high resolution in CT, for example, could make unnecessary a lot of the things we spend a lot of resources and money right now in terms of trying to calculate pressure drops by CTFFR and other mechanisms that cost a lot to society. If we were able to bring the technology, conventional technology, to the level of ultra high, we probably would be able to do much more and spend much less resources, or spend the resources on what would be really impossible to solve just by training and by enhancing a conventional technology. If you do that, then you're going to need less radiation, less contrast, and the hope or the possibility in MR there is really high. In other words, to reduce contrast using MR would be of great societal benefit. So this is an area where AI enhances conventional technology to the point where you don't need a lot of contrast, you don't need a lot of radiation exposure, and you also save resources in terms of healthcare, make it more available worldwide.
So that's a great response. And it looks like we are up till now talking about how do we best utilize a single modality. But let me ask Dr. Mackay. So on one side, AI can really enhance the performance of a single modality. What is the concept of a multimodality? Do you need multiple modalities then? How do you think we should balance in using multiple modality? What is multiple modality imaging currently in your realm in presence of AI?
Yeah, that's a good question. So right now, for standard non-AI related multimodality imaging, traditionally has been, for example, using the strengths of each of different modalities. So for example, with calcium, if you're looking for a patient, you're assessing severity of aortic regurgitation, or excuse me, aortic stenosis, for example, you can use an aortic valve calcium score if you're not able to get good flow gradients, or perhaps this is a patient who has low flow gradient aortic stenosis. Those are the areas where multimodality really shines. So if you have a patient who has a mean gradient that's over 40, then it's pretty much extremely clear that it is severe AS. The places where currently what I use for multimodality are those patients where are in the gray zones. I would say if you take it a step further and look at it from the context of AI, there's been a lot of really exciting papers that came out over the past year, as you may know. So for example, just in 2026, there's a nice paper by Fleury. So they were looking at unsupervised machine learning to enhance risk stratification in patients with asymptomatic aortic stenosis. So that's going back to Dr. Pasapati and Dr. Lima's question, how do you diagnose, what do you do? From a multimodality standpoint, what this group did was they actually looked at they also looked at lab work, lab data, CRP, et cetera, BMI, body demographics, but they also looked at other imaging characteristics from echo, for example, and also from CT to a certain extent, I believe. So by applying data sets from a particular patient and imparting and creating effectively a fingerprint, if you will, using different types of modality, there is a way to understand the assessment, the risk of the patient. And so the disease burden of the patient can be assessed a little bit more effectively using multimodality. The beauty of AI is that if you extend it to unsupervised learning, you actually lean in on AI to look at different patterns. You can look at it from a singular patient standpoint. Also, you can look at it globally, but you start looking and finding patterns that may cross different types of modalities. It may not just be echo, it can also be CT, it can even be perhaps in the future PET. So those are things to look at. And I think that's where things can change in the future.
Beautiful. So I think in the section on the diagnostic part, we really covered a lot of discussion and a lot of work that is going around in the field of unimodal or multimodal imaging, subclinical disease. And now I'm going to turn to Dr. Pasupati, because before we go to the section that's going to focus on treatment, I want you to talk to us about heart team and what's the concept of modeling in a heart team. What is a digital twin? What are these concepts? And then we will move on to actually the impact of the AI on interventions and treatment paradigms.
Okay, no, thanks for that. I think in the heart team, we personally haven't started using them in New Zealand, but that doesn't mean the concept is still not there. The AI is very good in making diagnosis, but it is not the best in making decisions from the diagnosis. So you really need a human integration with the AI diagnosis where you can get streamlined the diagnosis much better. So there's no conflict on your diagnosis. Like how Dr. Mackay said, there's a multimodality that you can bring in. And if you can bring it in a very quick sequence to make a very definite diagnosis, then from there, you need the human integration to actually how to decide how to manage these patients, because AI is not the best in some of the soft endpoints. If there's a patient too frail, is a patient not there? You need all those data points that AI doesn't really, at this stage, bring out all those outcomes. So there's a lot of future for heart team to literally integrate AI and to work with AI in the heart teams. You asked a little bit about the digital twins. Now, that is amazing because I'm an interventional structural cardiologist, and the digital twin is literally using a CT or an MR imaging to create a computer-generated 3D virtual replicant. So literally, you can actually see the patient's heart in a virtual replicant, which really helps you to optimize your procedure planning, to look at your success rates and your outcome, to use this digital twin. And recently, that's what I was telling, we were talking about using first in human cases. We literally can't predict a lot of things, how the outcomes are. And having these kind of digital twins will make a massive difference how you imply your therapy on those patients.
Beautiful. So, all right. So now you mentioned about a very important element, and that is the human in the loop, or you take all of the information and the human is making the augmented decisions. So I'm going to turn on to the section, and that is now we're going to start using AI for treatment, using all of this for all this innovation to really make decisions on how we're going to use therapy. So now let's bring back this conundrum. As the imaging becomes more quantitative and AI assisted, do you think clinicians will trust automated treatment recommendations, or will human interpretation remain central? I'll start with Dr. Lima to respond to this.
I think, the best solution, in my view, will be the trained physician who can use AI and who is knowledgeable to interpret what suggestions AI tools are making, but remain the human aspect remains at the center of the treatment decision. That is something that we can't substitute for AI, because there is an emotional and a human component to it, to medicine, that I don't think can be reproduced by machines. And that's the aspect that will, I think, be enriched by the presence of humans, of the doctor. The need for the doctor, I think, will be enhanced actually by AI tools and by more sophisticated recommendations and approach to treatment. Because one of the issues that are at the center of this, as Dr. Mukai mentioned, is trust. What you know that the internet is full of recommendations and examples, but the question is always, who do you trust? that's to make a decision, and who is able to sort out all this information out there, or the recommendations of these different tools to make actually a very to make human treatment decisions, and and that's why I think the ideal scenario will be the physician at the center of the AI world, as opposed to in the periphery of the AI
Okay.
AI centered medicine, basically.
And maybe I will ask Dr. Mackay. Do you agree with Dr. Lema?
Absolutely. I think right now with the tools that I use at this moment, they are AI. However, they're augmentative. So it's augmentative assistance. So AI is assisting me. For example, for plaque analysis, I rely on the AI. However, I do need to make sure the center line is in the center. We may need to reassess the thresholds. So there is an element of interaction that I still engage in for my day to day. So ultimately, as things progress and become more automated, I think that there may be improvements, but I completely agree with you, Dr. Lima. We have to have that human element, because remember, there's always the danger of bias. So if you blindly trust something, it's the equipment is only as good as the bias or the data that is transmitted in the data set. So, and that is a challenging thing to achieve right now, because you cannot conceivably cover every single potential scenario clinically. So I think that the human element definitely needs to stay front and center. And this really goes back to the discussions back, maybe in the 90s, people were saying AI is going to get rid of certain specialties, for example, medicine. I don't think that's relevant. I think that humans really need to learn to engage and use and embrace AI. However, we need to think of it as a tool, and a partnership is what we need to forge with AI, not exactly an antagonistic relationship.
It's so amazing that both of you agree so much to this concept of AI augmented work and human in the loop. But let me give a contrarian thought to it.
Sure. You
So
bet.
if the AI is going to be continuously requiring humans, are we going to get more busier? And because right now, like I think one of the ideas is that AI is going to give us more time, free up of our time, so that we can do some higher caliber activity, just like Dr. Lima was mentioning. We will go and be more human centered and human interaction and get more time. But if you're going to have AI always requiring human in the loop, I'm just asking this question: how do we separate what is autonomous and where you will really need a loop? Maybe I'll ask Dr. Lima to respond to this contrarian thought. Are we going to get busier and more burned out with so much AI in the loop for humans?
So far, this is what has happened with AI. Contrary to the prediction that the physician was going to disappear, what has really happened is that the physician has become much busier, and as you know, are now exposed to burden, and greater burden. So what I think the direction of AI should be to attain what you just characterized, an environment in which the physician can use the extra time to actually be a physician again, and spend more time being a doctor with a patient, transmitting that trust that one needs in times of in difficult times of disease and suffering.
So it looks like there will be a big need for being in harmony with these AI tools and learning how to manage and get the best value from it. And I think this is going to be a journey for us. And I think there has to be some ongoing education. And I'm glad that we are doing these sessions like that, which really bring forth some of the needs of how do you stay in equilibrium with AI working around you while you're making all the other decisions. And for those reasons, I will now turn to Dr. Pasupari with this question. For complex patients, structural heart disease and complex coronary artery disease, do you see AI primarily improving procedural planning, procedural execution, or even managing the patients after the procedure, what do you think is the role of AI in these entire gamut of activities?
I think it comes in three levels. I think first is the decision making. I think AI will really help you. Just say you have a complex coronary disease, even just let alone structural disease. The AI will actually help you to make the decision about who should be minimally invasively benefit and who actually will benefit from an open heart surgery. So that decision-making process, even in the structural heart disease, we are constantly faced with people with even just an aortic stenosis. Are you going to be better with a percutaneous therapy, or are you better with open heart surgery? Now, we all know the initial data will say percutaneous therapy is definitely a low-risk procedure. But we do not have data for lifetime planning for that patient. So if that same patient today gets a procedure, they will definitely have a low-risk procedure today. But is that the best therapy for the whole lifetime of the patient? So is the valve am I putting in going to last the life for the patient? If not, what's going to be the next stage? How is it going to interpret if I put a next valve in this patient, or should they have surgery now first? All of this kind of, there's quite a complex equilibrium to all of this, and each one of us actually do this in a subjective way. We have valves, we look and say this might be better, this could be better, I can put another valve inside this valve, this needs to be better streamlined. And I think AI will make a big difference in this interpretation in the complex structural heart disease.
But do you think, Dr. Pasupati, will AI support the augmented intelligence, or will it replace the clinical judgment? Because that's the central question we are continuously debating at the moment.
It will definitely augment, but it would not replace, because you definitely still will need that human element to it. If you look at medicine is half science, half art. And I think the art is very important in medicine. And AI is very much data set driven. It's multiple data set driven. You can't really put in art into AI very well. So when you see a patient in front of you, the numbers may say this is the best therapy, but that patient could be very frail, or patient might have other socioeconomic problems. Patient might have other work commitments. There are so many factors that come into it. You can't feed AI to take over all of this. You need to integrate science with medicine. And the science part also needs to be, like Dr. Mackay said, you will need to test some of the science, but that will get better and better with time. The quality will get better. We will have less time to test them. AI's accuracy will get better. But to integrate that accuracy with the art, you will always have both integrated working together. You would not be able to take over one over the other.
Yeah, and you know, this is a very important thing that you just highlighted. And I'm just getting reminded of a very important thing, that the current AI at least doesn't have a model of the heart or the physiology. It is just, as you correctly pointed out, it's just looking at the data and the interaction of the data. It does not understand the heart or the physiology or the biology like we understand, right? And also hallucinations. What about if it's suddenly hallucinating and giving you different directions? So it could be pretty risky. So I still feel like, I think it is not going to replace the clinical judgment, but I think I'm still a little thinking about what should we relegate to AI. Maybe, Dr. Lima, as you correctly pointed out, we can relegate all the segmentation and developing the models and contouring and the measurements, but we can move towards all of these higher caliber clinical judgment, interacting of a patient. That should be our human-centered and human-focused. Do you agree with that?
I agree. The world we don't want is where the wealthy person has a physician trained in AI, and the less wealthy person has only AI. That's the world we don't want. We want a world where AI make calculations and give you algorithms, but in the end there will be a physician that the patient can go to and make sure that the hallucinations, as you pointed out, are put apart, and that actually it's the patient's best interest that will guide the final decision.
Yes, a very important point that you just make me realize that I think I need to raise it to you. What about the digital gap, right? We have high-end imaging centers, as you pointed out, in wealthy nations who can use the AI. What do you think is going to require to make it equitable? What about resource-limited settings? Do you think AI will help there more, or will it be more in places where we have higher wealth and equity issues are something that I want to address?
I think that that is a point where AI can be extremely helpful. It can it can equalize the technology in areas where, in situations where you have a lot of difficulty uh, achieving or having access to the best tools. And this may not be just because of poverty, it may be because of remoteness, and isolation, areas that are isolated, that you can now provide the best of technology to make sure that decision makers there can actually make decisions with the best tools possible. I think that's a very good. That's the dream with AI.
Making decisions, I think that leads me to asking a question to Dr. Mukai. As the AI systems are becoming more autonomous, what level of explainability or transparency will clinicians need to feel comfortable about integrating them into practice?
I would say from my standpoint, especially as it relates to, for example, MRI, standardization becomes a very important thing. We're at the point where there's so many different AI tools available. So, for example, different equipment, there's different techniques to do even specific types of sequences, for example, in MRI. Having that standardization well in place and well documented, and having it pretty much essentially compared against large-scale multi-center clinical trial data, that is, I think, something that traditionally physicians we really look for, because we in our heart of hearts we want to do what's right for the patient, but you have to have the actual true endpoint data, clinical data. So I would say the standardization would be a very important element as we grow in AI. We are all quite advanced, and also the equipment companies are quite advanced in the features that they've developed. Some more so than others. And so as we look to trusting the quality of data, I think that's where the human element comes in. You want to have responsible stewardship of the data, and also responsible stewardship in the feature development, software development, or hardware development by even vendors, I would say. That is something that will be required and very, very important and vital to the trust element, because we are all, to a certain extent, we're trusting the data as it's presented to us. And so our ability to embrace it will be really dictated by how much we buy into the data, and how much we buy into the relevance of the data that's being created.
Very nice. We covered a gamut of different areas of diagnostics to treatments and complex decision-making issues. Let's try to now ask some important closing questions. Maybe I will start with Dr. Lima, because you have had the largest experience in the imaging field up till now. If we reconvene 5 years from now, what change in cardiovascular imaging would convince you that AI truly improved cardiovascular longevity? Because that's the area that we are talking about today.
I think what Dr. Mukai just mentioned, if I see that the playing field is made more standard, and that the technology that AI has enabled the technology to reach its best limit. And again, certain manufacturers, certain vendors are more concerned with that than others. I think that is the way to proceed in the future. Then I will know that AI is actually producing something that will bring societal benefit in 5 years, in 10 years, whatever time point that you think would be reasonable to measure the effect of having this technological jump.
Fantastic. Dr. Pasupati, what is the single biggest barrier right now that is preventing AI-enhanced cardiovascular imaging and treatment, etc., from having its biggest impacts?
I think the main barrier is the trust and the lack of understanding. I think if we can break that barrier with trust and better understanding, then I think we should be able to integrate this much better into our community.
Great answer. And Dr. Mackay, for younger cardiologists and imagers entering the field, what skill or mindset shifts would be most important in the AI era?
I think in the AI era, it's a mix of the artist and also the scientist, but also somebody who is ethically responsible for community. So I think you have to mix all three elements. You want to have somebody who actually is responsible to society, because we are working in a field, and actually this is a field that actually has significant societal implications for the world and globally, of course. So a person who understands the value of that takes responsibility and is accountable, but is also creative, because you have to be an artist to create multi-center clinical trials. So I'm sure Dr. Klima, you've been very prolific. So it's the artist in you that's creating that. But you also have to have a scientific mind, I think. You can have a creator, but having sort of, well, I'm biased because my background's in engineering, but an engineering mind is really, it's really fun to be in the space. But I think having an inquisitive mind at the very minimum, and an artist to a certain extent, but most definitely somebody who's responsible and who is willing to do what it takes to ensure that the quality of the data is accurate, and having that integrity, I think, is a very important thing to look for as we recruit people into this field.
Fantastic. So now the final rapid fire question for each of the panelists. One technology, workflow, or concept that you believe will fundamentally reshape cardiovascular imaging over the next decade using AI. I will start with Dr. Pasupati.
I think if the AI would come in and help with our reconstruction for 3D modeling and give us a more precise diagnosis, intervention, and outcome prediction, I think that will make a big difference in the structural world for me.
Dr. Lima?
I agree with Dr. Pasupati. I think digital twin technology will be probably the most impactful one to level the field and improve cardiology.
And Dr. Mackay?
I think probably non-contrast enhanced techniques as it relates to MRI. So for example, parametric mapping, I think there's a big potential there, because you can really that will basically release all the data that's living within most of the patients, that it's accessible without contrast. So I would say non-contrast parametric mapping holds a lot of promise.
This has been an amazing 1 hour of discussion, where we started off thinking about the paradigm of early disease detection. What is the impact of AI on imaging technologies? We are seeing tremendous growth in application in multiple modalities, concepts of unimodal enhancements, multimodality, complex patients, early prediction, to development of digital twins, and how finally AI is going to help us create the journey for the patient. In fact, it's no longer about reactive medicine. It's about how do we have the journey over the lifespan, where you can make decision moving forward. And AI is a companion for both the patients and also the physicians together to walk through this journey, so that we are able to anticipate the needed treatment and restore the wellness that is so critical. With that, I want to thank all the panelists for their amazing engagement. And I'm going to turn back to Kiran, because we're going to be open for taking some Q&As.
Absolutely wonderful discussion from all of you. I want to thank each and every one of you for taking the time to join us for this robust discussion on AI-enhanced cardiac imaging for longevity. We have had a number of questions come in from the audience, and we've got about 10 or 15 minutes left here in our time, so I'd like to try to address as many as possible. I'll start with this one here. This one is, will AI-enhanced identification of plaque burden be able to link the drug selection based on genetics? For example, targeted therapies based on your genome and AI-enhanced risk stratification to promote longevity. So it's a lot in that question. Who would like to take a stab at that first?
I can take it. I think, yes, I agree. I believe that there is a strong future for that. That will be within the research realm, of course, but you do have quite a bit of technology within plaque characterization. And I would say even in terms of fat attenuation, there are areas that is a growing field right now. So will they be able to? I would say with certainty they should be able to. I'm not sure within what time frame, but I think that the evidence and the technology that exists right now is ripe for the taking and for additional research.
Thank you for that answer, Dr. Mackay. Would anybody else like to comment on that?
I think also there are technologies now they are developing where, we are talking about genomic, but we understand that many a times diseases are polygenic. They're not just driven by one genetic change. So there is also another field where you can actually grow a tissue externally and see the response to the drug and therapy. So you can actually incubate the response and then use it if it's responsive. So there are many such amazing experimental methods that are evolving. Imagine the whole COVID-19 therapy was designed in computational world. I mean, there was no large scale animal work that was done. So I think there are amazing potentials. We are just about starting to knock on the doors of some of these technologies.
That's wonderful. Let's jump to another question here. What are some of the biggest workflow mistakes institutions make when trying to introduce AI into imaging programs? I'm sure each of you've got some experience with this. Who would like to take this one first? Maybe Dr. Lima or Dr. Sengupta? You first.
Yes, so I would say that the biggest thing is that whenever we apply a model, you have to do a pilot in your own institution. You cannot assume that what is being done elsewhere is going to work with you. So you have to make sure that the model fits into your workflow, your architecture. You have to really make sure it works with your patients, your scanners. There's a lot of need sometimes to harmonize these models to your own environment. And without that implementation step, if you just go and implement it, and you land up with a lot of problems. So I always believe that a testing phase, a pilot phase is very critical before you really implement it in a large scale.
Yeah, I couldn't agree more. Anybody else want to chime in on that, or should we move on?
I think a good example of what Dr. Sengupta just mentioned, just highlighted, is parametric mapping in MRI. Parametric mapping depends really on what is in your lab that is considered normal and what is that is considered outside the risk, in the risk zone, so to speak. So this is just to paraphrase that what Dr. Sengupta highlighted there, which I think is very important.
Okay. We'll move on to another question here. Which patient population stands to benefit the most immediately from AI-enhanced imaging? Maybe Dr. Pasupati, would you like to jump in on this one?
Yeah, I would, because I do a lot of work with aortic stenosis, and I would then actually work on that for you, to give you an answer. For me, the diagnostic paradigm of aortic stenosis, you think aortic stenosis is very simple to diagnose, but there is so much variations in aortic stenosis. There's low flow, low gradient AS, there's normal flow, low gradient AS, there is paradoxical low flow, low gradient AS. There are so many variations. The part that we really struggle is which one of these populations will benefit from intervention now and the ones you can actually follow, because there is also pseudostenosis. The pseudostenosis don't respond to the therapy with the valve, they respond to medications. They behave like heart failure therapy. So for me, in the field of aortic stenosis, I think it's very, very important to standardize therapy. And I think the AI has a major role here to standardize throughout the place, throughout the population, so people are not left behind and people are not overtreated with AS as well.
Very good answer. Anybody else care to comment?
Yeah, I would also say, so some complex diseases like amyloidosis, right? So it's a very complex disease, and there are therapies available, but people miss it because it's not, it looks thicker. Sometimes it looks like hypertrophic cardiomyopathy. We make mistakes. Sometimes actually the LV is not looking exactly like what you want to see in amyloid, yet the AI models in imaging or even on ECGs are able to pick that up. It's amazing. And that has led to large ability to identify these complex diseases earlier as aortic stenosis. So subclinical LV dysfunction in the population using ECG is another example. And there's so many different models that have come from different institutions. So I think these are classic examples of where application of AI has really made a big difference.
Thank you for that, Dr. Sengupta. Dr. Mackay, would you like to jump in on this?
I have to actually agree with what's been brought up so far. I think probably the valvular assessments is very important, and that's an area that has the strongest intersection between all the different modalities. So I would agree.
Okay. We'll jump to the next question here in the interest of time. How does the choice between a cloud-based and an on-premise cardiac imaging infrastructure affect your team's ability to handle increasing imaging volumes and utilization demands, particularly in terms of workflow stress, scalability, and even IT burden? Who will take that one?
I can say that this is a major issue in several institutions, and I'm going to include ours. With another issue there, which is security, data security. So it's a balance between it would be great if we could use the cloud without any preoccupation, but this is not exactly the case, and it will vary from institution to institution. So there will be situations where in the premise data storage will still be required by regulatory processes, but I think more and more the cloud will be the solution, having in mind that banks use the cloud, and so it is possible to implement security measures that the cloud becomes the main solution. We are just not there entirely right now for the health field.
And if I may add, that also depends upon the kind of application. For example, if latency is an issue and you don't want to be dependent on like presence of an internet linkage or not, and you think the cloud is not going to be available consistently. I think many times it happens when we are going and doing our scanning on the floor and you lose the cloud and the connection, and you see that the data doesn't transfer. So it all depends upon what we want to do. Many times having a local solution inside in the scanner is more important to get through the scanning very quickly than having to connect to the cloud. So it will be dependent upon what kind of work we are interested, what is the security issue, and also what are the latency issue, and what is the ability to quickly connect with the internet, and that's important as well.
That's a really, really good point. Really good point. Dr. Pasupati.
Can I chip in with one little word as well? I think our infrastructure, our health system is still not ready for the scale. The IT is unable to keep up with this AI technology that is growing so fast. And they're a bit unsure how to actually protect all of this data that is coming out in here. Okay, so for me, the cloud is a very, very important thing. The seamless integration into the cloud is still not there, which I really sometimes frustrates you. But it has really opened the way how you practice, because in my practice, I still travel quite a bit. And while I travel, I easily can I can do a full patient reconstruction, plan the case. When I come back, I can actually go and do the intervention for the patient. And this has completely changed the way how I used to practice medicine. I used to go to the cath lab, sit in front of the people, and then try and reconstruct this image. Now I can do 5 other patients when I kind of travel and do other things at the same time. But the seamlessness, the IT protection, the firewalls behind this sometimes drives it crazy. And hopefully once that is sorted out, I think this is going to be an amazing place to work with.
You concur, Dr. Lima?
Yes, but I think what Dr. Sengupta mentioned is very important. There are areas, for example, robotics and the kinds of work that Dr. Pasupati does, where it's Da Vinci was developed to enable surgery at a distance, but actually the time lag made it impossible. So it actually flourished in local surgery, and that is something that probably will remain for the time being until the cloud could be able to accommodate something as automatic as that.
Understood. All right, we've got time for one more question. I'm going to pitch this one to Dr. Mackay to get us started. As AI increases sensitivity for subtle abnormalities, how do you maintain meaningful communication with your patients without creating any unnecessary anxiety?
Yeah. So basically, two ways. In the reporting scheme, we always have a clause that most places should have that in the report, so that you actually say that this portion of the analysis was done with AI assisted technology. The other part is in the clinic before I refer patients for analyses. I do essentially try to explain this to them as best as possible. There are specific companies and areas where you can actually create a report using tailored data from AI. That can be potentially useful, but I would use it with caution. So the way to actually essentially at this point to temper the risk and anxiety is to really communicate. The physician will be the one that has to do it. So that takes the requirement and a different change in culture for the physicians using the AI technology.
Anyone else care to comment on that?
Yeah, I'll briefly comment on that as well. And I think the AI is going to make a lot of subclinical diagnosis, but these diagnoses needs clinical outcome. And I think that has to be educated to the patients and the clinicians, because so many subclinical diagnoses without long-term clinical outcome will only cause anxiety. And it's very important to work out what is important clinically for this patient in the next 5 to 10 years and what may not be an important thing. And the reassurance and the education is where we are lacking, and we need to integrate that to use the amazing amount of data that is going to be thrown at us in this part.
Yeah, and I would just like to maybe add that I think in my outline that I wrote, therefore it's important that when a clinician is encountered with this situation, he has to take the responsibility to ensure that the diagnosis that is available, either he's concurring because of the contextual information that he sees and he agrees with the interpretation. So the transparency of the model is important, but also have additional sets of information. For example, you take the ECG. ECG, initially, all the models had a high degree of false positives. It will label many patients as abnormal. And if the target is to look in for LV systolic dysfunction, maybe you use point-of-care ultrasound quickly in the outpatient setting to see that is there or not, and then provide that information. Because I think one of the quickest remedy to anxiety is to come quickly and make or break the diagnosis which it is suggesting, because you don't need to sit down and thinking and explaining. If you have a method to confirm it, go to that step and do it, and that should be cost effective as well. I think a combination of ECG and point of care ultrasound, for example, makes a lot of sense. Aortic stenosis detection, LVH, cardiomyopathy, so on and so forth. I believe a lot of these diseases can be detected very quickly using some of these cost-effective technologies.
Well, I think that's a great place for us to wrap up. We've kind of come to the end of our time here. Certainly on behalf of myself and my team here at Applied Radiology and our friends at Canon, I want to thank the four of you. I mean, just a super job speaking about a complex topic here, AI-enhanced cardiac imaging for longevity. You all really sincerely answered all of these questions, and we appreciate that, and shared your unique experiences from your institutions and your own clinical, background. So thank you all, Dr. Pasupati, Dr. Lima, Dr. Mukai, and of course, Dr. Sengupta for leading us as our moderator. Thank you all very much.
Thank you very much.
Thank you.
Thank you.
I'd like to remind our audience that as we wrap up here, there will be a survey that will be presented to you. It's also in the audience portal, but when you close out, it'll pop up. We would appreciate if you would consider that. I'll also remind you that there were resources in the resource area, an article and a couple of links, so you're welcome to those as well. And I'd just simply like to thank all of you for taking the time to join us. And finally, let me again thank Canon for providing the support for this program today. We do appreciate their continued support for programs like this. And with that, the program is now concluded.